Molweni unjani? Ndiyaphila nami Nkosi. Okay, hi everybody. So in this session, I'm going to speak about peptic ulcer disease. So let's say, for example, you have a patient that's presenting with hematemesis, vomiting blood, epigastric pain, burning sensation after meals, dyspepsia, bloating, heartburn, and on examination, you find mild epigastric tenderness. Now, the likely diagnosis is that of a peptic ulcer disease, right? Or more specific, you can say a gastric ulcer, okay? So this, what symptoms will make you think of malignancy? So if the patient is bleeding or have anemia, patient have early satiety and unexplained weight loss, progressive dysphagia, recurrent vomiting, and any family history of gastric cancer can allude you to a type of a malignancy. So let's say a patient presents with the epigastric pain and is burning sensation 2 to 3 hours after meals, mostly at night. A likely diagnosis is actually that of a duodenal ulcer, whereas a gastric ulcer you have the pain that is immediately after the meals, and also a gastric ulcer is worsened by eating, and a duodenal ulcer is actually improved by eating. The two main causes of peptic ulcer disease is that of H. pylori as well as non-steroidal anti-inflammatory drugs. Explain the pathogenesis of peptic ulcer disease. So, peptic ulcers, they are defects in the gastric or the duodenal mucosa that extend through the muscularis mucosa. Peptic ulcer disease can involve the stomach or the duodenum. Under normal conditions, a physiological balance exists between gastric acid secretion as well as gastroduodenal mucosal defense. And with mucosal injury and thus peptic ulcers occurs when the balance between the aggressive factors and the defensive mechanisms is disrupted. The aggressive factors includes NSAIDs, the H. pylori infection, alcohol, bile salts, acid, and pepsin. The defensive mechanisms include tight intercellular junctions, mucus, bicarbonate, mucosal blood flow, cellular restitution, as well as epithelial renewal. What are the three types of gastric ulcers? So you get pre-pyloric ulcers, which is less than 2 centimeters from the pylorus. You have a combination of duodenal and gastric ulcer. And the duodenal ulcer is usually inactive when a patient presents with a gastric ulcer. You also get ulcers that's more than 2 centimeters from the pylorus on the lesser curve, usually above the annulus. So, what's the risk factors for peptic ulcer disease? So, the risk factors again is that of the H. pylori infection, NSAIDs, lifestyle factors, stress, smoking, alcohol, severe physiological stress, hypersecretory states, which is very uncommon, as well as genetic factors. Looking at the H. pylori, what is the pathogenesis of the H. pylori peptic ulcer disease? So remember that H. pylori is a gram-negative bacterium found on the gastric epithelium and induces chronic inflammation of the underlying mucosa. An infection is usually contracted in the first few years of life and tends to persist indefinitely unless treated. H. pylori is associated with severe upper GI conditions, which includes chronic gastritis, peptic ulcer disease, as well as gastric malignancy. So it's almost like this triad of conditions which can be caused by the H. pylori infection. Moving on to the second most common cause of peptic ulcer disease, which is NSAIDs. What is the pathogenesis of NSAIDs? Specifically looking at brufen as an example. Now, these drugs hamper the mucosal permeability barrier, rendering the mucosa vulnerable to injury, and an increased risk of duodenal ulcers in the setting of NSAID use is seen in patients with a history of previous peptic ulcer disease, older age, so older patients, females, as well as patients with severe comorbid illnesses. Now, regarding the patient that you suspect that has peptic ulcer disease, what are you going to do? Obviously, we're going to do a gastroscopy as well as a biopsy. So for the ulcer, for the gastric ulcer, to detect whether it's either a benign or a malignant ulcer, and also the biopsy of the gastric antrum for H. pylori testing. And this would be done using a rapid urease test, or we can also send it for histopathology as well. So what if you can't do a scope? How can you test for H. pylori infection? So you can do the urea breath test or stool antigen assays. What features on endoscopy will tell you whether there is malignancy or not? So if it's a benign ulcer, they tend to have a very smooth, regular, rounded edge with a flat, smooth base and surrounding mucosa that shows radiating folds. Malignant ulcer will have irregular, heaped up, or overhanging margins with an ulcerated mass protruding into the lumen. The surrounding folds often appear nodular as well as irregular. So, how are we going to manage a patient with peptic ulcer disease? So, the main goal of peptic ulcer management is to relieve the ulcer symptoms. We want to perpetuate the healing of the ulcer, prevention of any complications, and also prevention of recurrence of the ulcer. So, very important. If you suspect H. pylori, we start with the H. pylori eradication, PPIs, and avoiding NSAIDs. Right, that's the mainstay. So, for H. pylori eradication, you need to have PPI, lansoprazole or pantoprazole twice daily for 1 week, in combination with a 1 week antibiotic course consisting of amoxicillin, 1 gram by daily. Um, it's supposed to be so amoxicillin or clarithromycin and metronidazole, okay, followed by daily PPI to complete 1 month of treatment. Now, endoscopy is usually 6 to 8 weeks after the initial. We would do another endoscopy usually 6 to 8 weeks after the initial diagnosis to document the healing of the gastric ulcer and to rule out gastric cancer. Now, when patients for medical reasons are unable to stop NSAIDs, maintenance PPI therapy is recommended. Okay. Refractory ulcers that do not completely heal after 8 to 12 weeks, so that's about 2 to 3 months of standard anti-secretory drug treatment, may continue daily PPI therapy indefinitely. Now, if the patient doesn't have H. pylori infection, it's negative. Okay, the urease and the stool antigen test came back negative. Biopsy is negative. Patient is not using NSAIDs. We can exclude the Zolina-Ellison syndrome should be considered. It's a triad of pancreatic adrenal tumors, gastric hypersecretion, as well as peptic ulcers. So, what are the indications for surgery of a patient presenting with peptic ulcer disease? So, the main indications are of the bleeding ulcer, perforation, stenosis, and occasionally for persistent penetrating ulcers. So, let's say a patient is throwing up blood. What are you going to do? So we need to resuscitate the patient first. During the ABCs, start with standard crystalline colloid solutions until blood is available. We should do a cross match as well. Blood loss must be replaced adequately and promptly with blood and blood products as necessary. And if the patient is severely shocked, we should put a catheter in for the patient as well. We need to do a history. So periodic dyspepsia related to meals or excessive analgesic ingestion is likely a peptic ulcer disease. Excessive alcohol intake and low known liver disease with stigmata of liver disease could definitely indicate esophageal varices, and an episode of repeated vomiting could indicate the Mallory waist T. It actually brings me to the initial differential approach to a vomiting patient. So, in terms of a differential diagnosis, the common pathology is Or usually I like to divide into benign and malignant. So benign and malignant, and then in the benign you have infectious and non-infectious. So infectious would be esophagitis and gastritis. Non-infectious would be peptic ulcer, esophageal varices, um, Mallory waste stay, warfarin toxicity, um, and hemophilia. And then we can just include the Homocystis pancreaticus from the chronic pancreatitis and the infectious cause under the benign heading. The malignant causes for vomiting blood would include that of a gastric carcinoma, esophageal carcinoma, or a GIST, which is a gastrointestinal stromal tumor. So yeah, that's the differential of a patient that is essentially vomiting blood. So in the examination, you want to assess the hemodynamic status of the patient. Okay, you want to check the cardio, respiratory, hepatic, and renal status of the patient. Major hemorrhage will be associated with the clinical findings of hypotension, decrease in blood pressure. Patient is pale, congenital pallor or palmar pallor, a weak and rapid pulse, so radial pulse, probably, and poor peripheral perfusion with very cool extremities, so you want to feel the hands as well. In the majority of patients, these findings will be associated with systolic blood pressure of less than 100, so it's hypotension and tachycardia of more than 100 beats per minute. We need to look for clinical evidence of chronic liver disease and portal hypertension. Encephalopathy may be in the later stages, jaundice, yellow sclera, or even yellow palms as well, spider nevi, palmate edema, fetal flapping tremor, and ascites as well, which definitely suggests the presence of esophageal varices. You'll also want to do a rectal examination, check for melena or black tarry stools, which suggest your upper GI bleed, and the black and the melena is formed by blood mixed with acid and indicates that the source is in the upper GI tract. What next? So you want to do a baseline hematological and biochemical investigations, and it should be requested together with a cross match, okay, for of blood. So you want to do FBC, and intervals with E, and then the cross match. Now, the resuscitation of patients who are suspected to be bleeding from esophageal varices due to underlying liver disease differ from that of other patients. We should not use sodium-containing crystalloid solutions, and such solutions may lead to deterioration in the liver functions as well as ascites. They should be resuscitated only with blood at 5% dextrose and given fresh frozen plasma to replenish the clotting factors and receive octreotide to lower the portal pressure. Okay? All upper GI bleed patients should receive an intravenous proton pump inhibitor, as this can downgrade the lesion. The raise in gastric pH can aid in clot stabilization as well as allow hemostasis to occur. What next? So you want to risk stratify your patient and use the Blatchford score, the modified blood score, which consists of the blood urea as well as the hemoglobin for men and women respectively, systolic blood pressure, and the pulse. Now, the Blatchford score of 0 to 1, you can discharge the patient early with a date for urgent scope, upper scope for 1 week. A score is equal to 0 if the following are present. So the HB is normal for men and women, more than 12.9, 11.9 men and women respectively. Systolic blood pressure of more than 109, or yeah, more than basically 110 or more. Pulse of less than 100, blood urea less than 6.5, normally no syncope, and no liver disease or heart failure. For the score of 1 to 6, you want to manage the patient in medical wards. Give oral PPIs and scope within 1 day, so within 24 hours. And remember, the score of 6 or more are associated with a greater than 50% risk of needing an intervention. If the score is more than 6, though, you want to admit to surgery, give IV PPI, and scope also within a day. Then, if the score is more than 10, you must scope within 6 to 12 hours, okay, because it's obviously more urgent, okay? And I think that what that also describes as well. Okay. With regards to endoscopy, so what next? You want to do some endoscopy. So emergency endoscopy is performed for patients with evidence of ongoing bleeding after resuscitation. Okay. Um, and that is basically normal for men and okay. So that is basically detected with persistent tachycardia as well as hypotension. And the high-risk patients, such as the varicose patient and the MBS of Mornington, should have urgent endoscopy within 12 hours of admission. All other patients should undergo a full diagnostic endoscopy within 12 hours of admission, whether clinically stable and have been fully resuscitated. Follow-up endoscopy may be indicated during the course of the initial admission if there is doubt about continued bleeding or the source of bleeding. So how do you classify a bleeding ulcer? So you obviously you have one, two, and three. So with the first level, it depends if there's bleeding. So with one A and B, there's bleeding. So with one A, there's a visible vessel, so you have spurting of blood. One B, you can't see the vessel, but there's oozing of blood. Two A, you have no bleeding, but there's a visible vessel. Two B, there's no bleeding, but there's a clot, right? So you can't see the vessel, there's an adherent clot. With 2C, you have a spot. Okay, you have a pigmented spot, and 3, you have a clean ulcer base. What next? So you want to manage this patient. With medical management, the main aim is to increase the gastric pH to above 60 in order to prevent the clot lysis. So you want to give IV PPI, and you can change to oral once the patient is stabilized. You want to monitor the vital signs. Look at the HB, you want to monitor the electrolyte levels as well. You want to give blood transfusion if needed, and then also you want, if you suspect the H. pylori, you need to start with the H. pylori eradication, which consists of obviously your PPIs together with the amoxicillin slash um, clarithromycin as well as metronidazole. Endoscopic management, you're going to need diluted adrenaline in a dilution of 1 is to 10,000 with thermal coagulation as well as clipping devices. Surgical management, so the primary objective of surgery is to secure the bleeding vessel with a non-absorbable suture. A board of one partial gastrectomy may be required for gastric ulcers when underrunning of the bleeding site is not technically feasible or in cases with large penetrating ulcers. Okay, so which patients are at risk of rebleeding? So age, patients over 60 years old, shock on admission, tachycardia, hypertension, endoscopic stigmata of recent bleeding. So splitting vessel, visible vessel, and fresh clot in the base of ulcer. Large ulcers, more than 2 centimeters, are at risk for rebleeding, as well as lesser curved gastric and posterior duodenal bowel ulcers. What are the indications for surgery? Failed endoscopic therapy of active bleeding ulcers. Recurrent bleeding after endoscopy therapy. You had two failed endoscopy management attempts and associated perforation, which is quite uncommon. And that's it for peptic ulcer disease.